far we have got thus far in our discussion. We thank you for the strength and the motivation. Lord, we commit to this discussion to you. We have that you will guide us, you will help us to get the best within the time allotted. Thank you because of answered our prayer. In Jesus' name, we pray.
Amen. Question number 40.
Well, can I even see very well?
Ouch. This
Not very clear.
Okay.
Even the memory shows scattered microcalcification on the lens of a 54-year-old woman. Call everybody who's concerned. Each of the following is the most appropriate next step in the treatment. Oh, this usual or
read.
What do you have?
We all in different fields and sciences. And
wow.
it doesn't matter if you are or
I'll just take
I'll call it columnar cell changes, right?
yeah, I'll call it a typical doctor aphasia. Is it typical, sir? Let me see more slides.
your body.
This one look like columnar cell, but the other one look like those two slides.
So one of the
I will take A as the answer.
C.
Let's see.
I'll take C.
And get up
Why C?
and go.
What is the treatment for a typical doctor aphasia?
ADH. I don't think we're going to. I think it's excision. Why should you do radiation?
Okay, it's a excision actually, but when I didn't see that,
Maybe D. Maybe D.
Okay, come.
Well, whether A or B, let's see. Oh, E, but
Okay. Exercise is good for all the stuff inside your body, like your heart. See the heart. Where's your heart? The heart is here. Is the body.
you're right. ADH. Right. ADH.
Heart. We also have
Look
bone.
before me here. So that actually have people the nucleoli. Understand? Answer is D. Surgical excision through the more serious process.
okay, this thing is double. It's not enough to have it's two steps. You must know the diagnosis and then treatment.
I think that is what they say.
Inside your body.
I said that, there are two steps question. You must know the diagnosis and then treatment. If
Yeah,
you know the diagnosis and you don't know the treatment, you still miss it.
yeah. That's why I said, I was thinking that this is columnar cell changes, but this place is it doesn't. This looks like columnar cell change. However, if you come here, you see that. Let's see.
Mm.
Yeah, that's correct. This is I was right actually. This is columnar cell changes, but it's flat epithelial atypia FEA. Because it's not typical.
Okay.
ADH is just DCIS. But this
Okay, let's see what they wrote. Oh.
ADH is
They have ADH. He has something about ADH. They also wrote, let's say, this one is still a muscle. The image shows columnar cell change with
flat,
look now, let's read it.
flat epi.
Let's read what they wrote. With atypical. Let's see. John, I would like to read what they wrote here.
ADH here too.
Let me read what they wrote
ADH.
in the set of in the
So these are just
okay.
the Danish changes that are concerning.
With flat and atypical doctor aplasia. So both are there.
Yes,
Like this one,
this one here.
where you are going, it look like Roman bridging.
Which one? This one, I mean.
Yeah, where your arrow is.
Yes, including this one too. I think so. So I think this ADH. This is columnar cell, and this
Yes, both.
classic columnar cell changes. The flat atypia.
What is this?
Level of FEE, flat epithelial atypia. Level of that before.
Yeah. Mm.
So I'm going to discuss this. Then you discuss the question itself. So like we said yesterday. Let me quickly get sorry, I'm so sorry. So let me get a drink, a lemon drink to keep my brain active. Sorry. What's 1 minute?
1 minute. Pick them on you want to do one. This had to do. Exercise can be exciting. When you just put small. You're not ordering it on Amazon. Exercise can be exciting. Yeah, exercise. When you hit a home run or you score a goal. So when you're playing football,
Nice for now, so that nobody will be problem. Okay, sorry, I'm back. So differentiate the three.
Oh.
okay. When you're playing football,
So I'm listening. Can you differentiate the three?
the ball into the goalpost to score.
Mm. For columnar cell, it's like a cyst with secretion, and then it's lined by epithelial cells, bland epithelial cells. But in this case, it's lined by multiple layers of atypical epithelial cells.
Sometimes you might strike.
Okay, while we're waiting to get it, let's review details. Let's start with columnar cell change.
Or
This cells are learning this. These cells are learning the cystic spaces. Now, this is what we call columnar cell change. They look like the dots, instead of being cuboidal or thereabouts, look columnar. And the cells, like the columnar cell changes, are uniform. They're also oval, sometimes elongated, and they're oriented perpendicular to the basement membrane. The basement membrane is flat, they are standing vertically.
They look, they appear pseudo-striated.
I didn't get that.
Pseudo-stratified.
Yes. The cells show dispersed nuclear chromatin, nuclear polarity with nuclei located basally. Nuclei are basally located. Once apical
Wait.
cytoplasm, and they lack atypia. So it's that said atypia in columnar cell changes. I think that's what they call it. That's what they call FEA. But I'm not sure. Let's continue our journey. Flat epithelial atypia. Several layers of mildly atypical cuboidal cells. And they have apical snouting. You see the snouts that look like undulations. There's another name for these undulations. Apical snouting, what's we call them? What's another descriptive name for this kind of corrugated surface in pathology? It's called hobnailing. It's called hobnailing.
Hobnailing, it's like the reverse of this.
How?
The nucleus will be on top and the cytoplasm will be below. Abi? Yes.
But I think hobnailing to me is just corrugated. When there's some kind of corrugated
Hobnailing is like you have a nail. You are nailing a nail to the surface. So you have a long part and then the round edge of the nail on top. So the nucleus is the round edge of the nail. Then the cytoplasm, that abundant cytoplasm, is the one that now come below it. Like you see in the stellar reaction.
I'm not sure. Let's take a look at the picture then, and let's confirm it. Let me see if I can get a picture. Let's see. Hob nailing pictures.
Let's continue reading.
Like the hobnails. Oh, this is what we call hobnail. You see that's on corrugations. Let's see. Can see this corrugation like this, similar to this
Yeah, that's what I'm saying.
hobnail.
Is it corrugation?
Look at this.
Yeah.
You can see hobnail.
Can you see that the nucleus is on top
I don't know.
and the cytoplasm is below?
Is it? So nucleus have to be on top of hobnailing and cytoplasm below.
Yeah, yeah.
Wow, I didn't know that.
Exercise.
Can you see all this one too?
Make new friends.
It's like the nucleus is resting on the cytoplasm.
See that it's time to
Bulging nucleus. Yes, resembling a hobnail. Yes. Amen. So mildly atypical combined cells with atypical snout. So these are what we call it atypical snouts. Wow, very good. Atypical snouts, lining a dilated sinus. The round monomorphic cells in this proliferation are sufficient for classification as FEA. Image. The round monomorphic cells are sufficient for classification as FEA. Okay. So the definitions are present. So this case, that means what we saw before could be evidence for flat epithelial atypia. Because the source of atypia wasn't really determining ADH that much at some part. So this is apical snouting, monomorphic cells from atypia. An important clue to recognizing FEA is stratification of the nuclei. The nuclei will be stratified, and there'll be like here, what's the stratification of nuclei? And perpendicular, and there's that perpendicular, and that perpendicular orientation, perpendicular to the orientation to the base membrane. Basement membrane. This gives an overall disorganized appearance. Look at this. So so which of this is tubular carcinoma? Which of this is flat epithelial atypia? So look at here. So here we have a columnar cell changes sometimes. So we have columnar cell changes and it's having atypical cells with some apical snouting. We call it flat epithelial atypia. And they can be found in more advanced lesions, such as tubular carcinoma. So when you see flat epithelial atypia, it may be a sign that there may be tubular carcinoma or something more sinister, which is telling us that we should go ahead to excise it to look for more things. Molecular studies have shown genetic changes in columnar cell lesions that are similar to those found in tubular carcinoma, supporting a non-obligate precursor relationship, in the sense that sometimes columnar cell changes like the atypical one, like FEA, may predispose to tubular carcinoma. Columnar cell changes with classifications. These lobules with columnar cell changes have cystically dilated AC9 with luminal secretions and classifications. These lesions are most commonly detected as mammographic classifications on mammography. The terminal ductal lobular unit in columnar cell change show prominent cystically dilated AC9 that are more irregular in shape than those seen in FEA. That means in FEA, the terminal ductal units, the ducts are not very enlarged. This is FEA. You know, they are more regular, they are not more undulating, whereas this one, sorry. The AC9 can be
more irregular in shape.
Yes. Classifications can be present in any of them.
That is secretion with classification.
Yes. Columnar cell changes can easily be detected at low power. So the columnar cell changes at low power due to the dilation of the AC9. There's an adjacent, these are not uninvolved units. Uninvolved units. And these are dilations of the lobular units. Be going, please be going. Dilation of the AC9. Okay. columnar cell changes are usually more dilated. Flat epithelial atypia are less dilated, and columnar cell changes have more undulations. Columnar cell change, physically dilated, luminal secretions, uniform cells that are columnar shapes with nuclear polarity. That means the nuclei will be at the base. Nuclear polarity that lack ATP, and nuclear polarity here lack ATP. Okay. This columnar cell hyperplasia. So how do you differentiate columnar cell hyperplasia from columnar cell from flat epithelial atypia?
Hyperplasia is the columnar cells are blind. They don't have ATP, are they?
The hyperplasia, you have more than 2 layers of uniform cells. So usually columnar cell changes just have 1 layer with polarity. At most, some areas that appear like 2 layers. When it's having more than 1 layer, more than 2 layers of uniform cells that are not atypical, like in the cells, you will think of columnar cell hyperplasia. So if it's 1 to 2 layers, that's columnar cell atypia. Columnar cell changes. If it's more than 2 layers, that's columnar cell hyperplasia. For flat epithelial atypia, yes, you have nuclear stratification, rounded nuclei, and there will be cytologic atypia. Some pleomorphism, prominent nucleoli, clear chromatin. What does clear chromatin mean in terms of biochemistry?
Chromatin is within
What does clear chromatin mean?
the nucleus, right? Like, I feel like particles within the nucleus.
Chromatin. Chromatin is actually the areas of gene, right? So when you have that's chromatin. So when you have dark areas of chromatin, what do you call that in the nucleus? Heterochromatin.
Okay.
What if the chromatin is light staining, like clear chromatin or vesicular chromatin? What is that? Euchromatin.
Okay.
Euchromatin.
Okay.
So euchromatin, what does that mean? That the genes are not tightly packed. You know, when you pack genes with histone proteins and all that, you then make them into heterochromatin. But when they are loosened and open for gene expression, that's euchromatin. So when you see cells that are more open chromatin there, that means there are a lot of gene expression going on in that nucleus. You know, so it means the very increased nuclear activity. Unlike heterochromatin, which is a dormant stage of the nuclear. So, so the involved. Thank you for correcting me on this hobnailing. I've always thought anything that looks corrugated or snouting is hobnailing. I didn't even know that what it meant. Well, I have to be very careful whatever term I use to be sure that I understand it.
Apical slant is the reverse of the upnailing. The nucleus carry the cytoplasm on top. So apical slant. But upnailing, the cytoplasm carry the nucleus.
No.
So upnailing the cytoplasm.
Which textbook did you see that?
Actually, I've been practicing histology before you.
Actually,
I took a break.
I've never read about it before, Sha. But I've been seeing it. I've just seen people saying hobnailing. It's for one people are saying that I picked up. It's not as if I've ever read about all these things. So wow, that's good. It's good to actually define what you are looking at. So look at this. Is this columnar cell hyperplasia Is it columnar cell change or flat epithelial atypia, and why?
This place, let me see. We're going to call this one now. Let's call this Comoros hyperplasia. Are they atypical? Are they looking
There are
atypical?
more than two layers. But can't you see some areas have open chromatin and they have prominent nucleoli? With prominent nucleoli, open chromatin, multiple layers,
Yeah. True.
some apical statistics will now be some tetralytic atypia with chromatin changes and punctate nuclei. This will be flat epithelial atypia.
These chromatin changes are punctured. Mhm.
Okay. Wow. What do we call this?
Flat epithelial atypia.
Flat epithelial atypia. Why?
In the lining cells, they are more than two layers and they are atypical in appearance. Prominence.
They don't have the more than two layers, but at least they are multi-layered. And they are
Okay.
with some large cells. There's apical snouting.
Pneumorphic,
And what else?
large nucleus, prominent nucleoli.
What is this?
Is that mitosis?
Yes.
Typical mitosis.
When you see something like this, flat epithelial atypia, don't distract the patient. Look for cancer. This what is this? FEA, CCC, or CCH?
Mm-mm. What's this within it now? Is this secretion?
Classification.
Oh,
I think it's a crystalloids. It's a called it crystalloids.
but this crystal is not applying, it's not looking purple, it's looking pink.
So,
Uh, like all this, well, cholesterol crystal is usually white. Oh, it wants to resemble cholesterol. Yes.
okay, continue. Oh, okay, so what is diagnosis?
Hmm?
The diagnosis.
Flat epithelial atypia.
FEA. Or
It will look like ADH. Okay, because this is
the micropapillary DCIs. Okay. Remember
oh,
the
how is
vascular.
it different from ADH here?
ADH is the same now. What I said, ADH will be less than 2 cm. They don't give you a size criteria. We'll go for DCIs.
So in this microscope, do you know the size? You
Yes,
measure it.
I measure it.
Hmm?
Yes. If it's more than 2 millimeters, you call it DCIs. And these micropapillary forms, a lot of times, are going to be DCIs. Micropapillary, you know micropapillary?
Hmm.
All hyperchromatic at the top. The base will be narrow. There will be no fibrovascular core. They will be monomorphic in appearance. So ADH is like low, grade 1 to grade 2 DCIs. That is small.
Yeah. I count two
What
blocks.
is this?
Red, orange, then yellow, green, and blue.
Wow. This is like a frank answer. Is it customer city?
DCIs. Yeah, this is DCIs. There's some hobnailing anyway. We see one hobnailing here.
Hmm.
The nuclei are very pleomorphic. So according to them, I would have called this, because of the significant hobnailing, I wouldn't even want to call it. Normally, I expect apical snouting to call it FE, but I can't call it FEA. Because of the hobnailing and it's still in the duct, this is still DCIs. But it's a special sign of DCIs. It's called the clinging type DCIs.
Okay.
So what is clinging type DCIs?
Maybe because of that appearance of the nucleus, the look of Lenny.
Yeah, they are clinging. One are falling off.
Let's count now.
Some are clinging. So FEA is very pleomorphic and has significant hobnailing.
Just physical word.
Okay.
No.
What is it? What's the definition of CCC?
Communal sex changes. Maybe the R60 dilator is lined by bland epithelial cell, coronal epithelial cell. They have secretions and
Look
sometimes calcification.
at what they wrote here.
What does physical word?
I read this.
Where?
Yeah, my right hand.
Okay, 1 to 2 layers of columnar epithelial cells lining dilated terminal duct lobe units.
What of TCH, colonial cell hyperplasia?
Okay, more than 2 layers.
FEA.
Monomorphic covalent to columnar cells with mild nuclear ATP in dilated incineration.
What if the ATP becomes markedly pleomorphic? What will you call it? We used to call it FEA. But look like FEA.
DCIS. If it's looking like this, we call it DCIS.
What type of this size?
Four. Count four.
Clinging type this size.
Okay.
When they look like FEA, they see they have tissue stratified epithelium, but significant pleomorphism
Count
and
four.
hobnailing and all that.
4 blocks. 4 fingers plus 2. Is equal to
3 of them are all monoclonal proliferations, and they arise from genetically altered cell.
count 4 fingers.
One
See
single
my
genetically
fingers.
altered cell. They have lots of heterozygosity as
4
16q.
fingers plus 2 fingers. How many fingers?
Steps of
Equal to
spinning.
what?
They're going to be
Count my
positive for
fingers.
low molecular weight cytokeratin, CK8, CK18. They're negative for CK56. Okay. What other ductal lesion, benign ductal lesion, is positive for CK56?
CK56. Benign ductal lesion.
Yeah? I didn't get that.
I didn't get what you say.
What other lesion is positive for? What lesion is positive for CK56? Benign lesion.
Which one?
So what other lesion is
Okay, benign hyperplasia. Usual doctor.
UDH? Very good.
Hmm?
UDH.
UDH. Okay.
Yes.
5 plus 7. 5 plus 7 is equal to
Okay. FE is equal to 2% of poor biopsies.
5 plus 7 is equal to what?
Women 50 years. And you see group amorphous classifications on mammography. What's the treatment of CCH, columnar cell change, and columnar cell hyperplasia?
Just follow up.
Yes, no, it doesn't require surgical excision. What if it is FEE?
You exercise. Then you look for sinister lesion like tubular carcinoma.
Say if it's the only lesion and radiologic pathologic correlation is strong, excision is not required.
5
So if the only thing you have is FEA
5 red blood
and you don't have any other thing like DCIS or those other thing
orange
or ADH, no need to exercise, especially if your radiology supports it. In that case, risk of upgrade to carcinoma on excision is less than 5%. You know, the grade in why you exercise is that you want to look for cancer or DCIS. Even low grade DCIS, you no longer exercise or thereabout, if you can remember. Do you exercise low grade DCIS? No, I think we exercise, but we exercise up to 2 millimeters. But for high grade DCIS, up to 1 centimeters margin. Otherwise, you do radiation also. If exercise, cancers tend to be small, less than 0.5 centimeters and low grade. In terms of prognosis, columnar cell changes, columnar cell hyperplasia, and flat epithelial atypia carry a 1.5 times increased risk of future breast cancer. The same thing as UDH or papillomas. Wow. So even if it's called FEA, it's almost like UDH. And that is a 5 to 7% lifetime risk of cancer bilaterally.
5 plus 7 is
These are not considered high-risk lesions requiring screening or chemo prevention. Imaging.
And number 6.
They're usually associated with mammographic calcifications, and they don't have any grossly or palpable masses. Microscopy, dilated acini, 1 to 2 layers of columnar cells or columnar cell changes. You see epithelial now, luminal secretions, calcifications, uniform nuclei oriented perpendicular to basement membrane. Columnar cell hyperplasia, similar to columnar cell changes with stratification between 2 layers. Cells form tufts or mounds, but not micropapillae. Still lacks architectural complexity. FEE is monomorphic cuboidal columnar cells with mild atypia. Nuclei may be round, enlarged, or loss of polarity. No architectural complexity, like no bridges, no micropapillae, no cribriforming. They may coexist with ADH or low-grade DCIS. They have ADH or low-grade DCIS, they have to excise it. What's the risk of progression to cancer for ADH?
ADH. That should be 4.
4 to 5 times, yes.
We are counting
Molecular features, loss of 16Q. Analysis complete 9Q, 10Q, 14Q, 17P. Gains are 1Q, 15Q, 16P, 19P. The shape for ER diffusely and strongly. Low molecular weight cytokeratins like 8 and 18, but they're negative for high molecular weight keratin like 5 and 6. And that one to differentiate them from UDH. Sometimes you'll be thinking, is this UDH or is this FEA? UDH will stand for CK56, whereas FEA will be negative for CK56. Differential diagnosis will be epichromic aplasia, abundant eosinophilic cytoplasm, round nuclei, nucleoli, and mimic CCC. ADH. This show architectural atypia. micropapillae, cribriform, arcades. FEA lacks architectural atypia. Like all this Bowman bridging, we find that all with ADH and DCIS. Whereas FEA will just be like cystically dilated cells with apical snouting. Flat high-grade DCIS. High-grade nuclear polymorphism. Then columnar cell lesions without myepithelial cells. Rare. Resemble carcinomas, usually locally infiltrating with unknown clinical significance. Let me ask you this
No
question.
longer clear.
Are you there? Are you there?
Yeah, I'm there. I said the screen is not clear.
Let me share the screen again. If you have, if somebody excised breast to breast biopsy and sent to you, and you see columnar cell changes only, will you send out the biopsy as benign breast tissue or benign breast changes?
Yeah, I can sign it on like that.
That's what they are saying here. We have to examine this. You know, you have to tell. The question is, did somebody just see a woman with a breast tissue and just liked to biopsy her? No. They saw something that made them biopsy her. What did they see? Calcifications. You know, here, when they biopsy breasts, they will tell us breast biopsy with calcification or without calcification. If the radiologist saw calcification and felt that that calcification falls in one of the things you should biopsy, you know, they have criteria for biopsy calcifications. It looks suspicious or malignant or something. And the biopsy calcification they send to you, they expect you to identify if there's calcification or not. In my program, if you don't see calcification under the microscope, you have to go and x-ray the block to see if there is a calcification. If you see calcification in the block, you have to try to keep sectioning the block until you get slides that show the calcification. You not just want to make sure that they didn't biopsy the wrong site. They want to find out what is causing this calcification. So if you say benign breast changes, you will not help them at all. You have to tell them, is this calcification associated with columnar cell changes? Is it associated with columnar cell hyperplasia? Is it associated with flat epithelial atypia? Is it a UDH? Is it an ADH? Is it a DCIS? Is this so they want to know why there's classification there. So you must report. It's really wise to report. Otherwise, they will call you. Maybe you're supposed to be sleeping or going home. They will call you. They now go back to your computer. They are saying, what about this case? What caused the classification or something like that? So you have to report, even though there are benign skin changes. I used to wonder, why do I have to write up and say, this is benign breast, I see no cancer, I see no disease, and I will say epicrine metaplasia present, columnar cell changes, what else? Columnar cell changes, UDH, all kind of things. And then why do I have to report all that? Is because the clinicians want, radiologists want to make sure that they are correlating their classification with some findings. Sorry, I spoke long. I don't know if it's clear.
So 0. That would be cramming.
Are you there?
What kind of the F14 is that one?
Yeah.
4 to 14, your video.
Did you get that? Did you get what I said?
0.
The one I read was about classification.
What? Nothing. Who want to beat you?
Okay. I
And
said,
okay, I'm listening.
when radiologists biopsy a tissue on the breast and they say the tissue is associated with calcification, they will send it to you in the precision paper as breast biopsy with calcifications. They don't want you to write benign breast changes. They want to find out exact things you saw so that they can correlate it with the classifications that they saw. So if you see columnar cell changes, you have to write columnar cell changes with microcalcifications present in the duct or stroma. That will also give them confidence that the biopsy in the right place. Because the biopsy in the wrong place, maybe that's why we are not seeing the classification. So they don't just want to make sure that there's classification in the block or in the slide. Are you with me?
Mm.
You don't get that, sir?
Actually, I know a little.
It's so okay, so turn it should be your turn to
Okay,
discuss.
so let me see.
Huh?
Perform deeper levels.
Yeah,
Submit all.
very good. You see what I'm saying? Anyway, you know, remember that we can section the blocks now. If you see FEA, and that's the only thing you find, you don't find other things like ADH, DCIS, columnar cell changes. Do section and get more levels. Then for the breasts, you submit all fibrous tissue for histology. Do you know that you know that all these lesions are non-breast, non-mass forming lesions? How do you gross it? How do you what's your protocol for grossing these cells in your place?
We don't have any special protocol for it. It's the same protocol for breast generally.
If you want to gross breast, you ink the breast.
Sometimes, but most time we don't. It's just that you properly label it. Like this is medial margin, this is anterior, this is lateral, and all those.
So if you don't ink it, how will you know under the microscope that this is the margin?
You would have labeled the block now. When you take the sample, you label the block.
Oh, okay. Label the block that this section contains the margin, right?
Yes, control lateral margin.
Okay. Wow, but it's because you don't do margin, you don't do measurements of to margin. Do you normally do measurements to margin when you sign out cases?
No, maybe some consultants do that, but not always.
Okay. But like
You
now,
know that you state there whether margin is involved or not. You always tell the clinician whether if the margin is involved or it's not involved.
okay. Now you have to, you know that it's okay. So when you talk about these changes, protocol for growth, normally if you have a breast cancer, we submit 1 block per cm.
This is G.
But the thing is this, these lesions are what we call non-mass forming lesions. You're not going to see any lesion, any mass. So what you do is submit the entire fibrous tissue of the breast, especially if it's a small tissue like lumpectomy. If it's not lumpectomy, then we have to we have to map it using X-rays. We have to map the fibrous areas on X-ray and submit. You know, sometimes you have to take in fact, usually you map your breasts. You map the breast you're going to, so you do mapping of the breast specimens you're going to submit. I wish I can show you example. Okay. Okay. So you perform deeper levels and then to look for if it's only FEA that you see, you submit more levels, submit all fibrous tissue for histology. That's what that's the protocol I'm telling you. Look for ADH, DCS, or invasive carcinoma. So you don't exercise for any of these. The only reason why we exercised in this case was because it had the ADH. So over to you. Can you explain this slide? Can you read and explain all that is in this slide?
Well, colorectal cell changes with plant epithelial. and atypical Doppler hyperplasia. The image shows columnar cell changes with apical cytoplasmic plebs or snouts and low-grade atypical consisting of stratification and disorganization of the epithelial lining, loss of polarity, loss of perpendicular orientation to the basement membrane. I think all that is in this left section, this lower left section.
You can see myself.
Nuclear enlargement, nuclear macro. One dot on the right contain cribriform spaces and a bridge with streamy cells, more typical of ADA than BCIS. So
This is
that this one on the right.
the bridge. What are streaming cells?
Cells that are streaming like.
So you know what streaming cells are?
Well, maybe it's the cells that lay up that bridges. Stream is like something moving from one end to another. I know I've not read it, but I just
So you mean
you know
what's under the bridge?
the cells that made up the bridge. The bridging is that the cells move from one end to another now. Abi?
Yes.
Swimming cells are within doctor or insular structures. Okay. You have removed it. Is that what they said?
Yeah, they say architectural and psychological clues supporting the use of I want to make, I don't know, a streaming within a bridge. You're right. Maybe the cells streaming along the bridge, within a bridge.
Within a bridge indicates partial preservation of cellular cohesion.
Typical of what? Okay.
John, I think we have tried on this question. No?
Right? We are done.
I
Okay.
think we have tried for this question. Let's move on to another one.
Okay.
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 You can get MCQ.
Okay. You say we should do MCQ or we just do another question?
Oh, let's do the MCQ and then go to another question.
Okay.
Now let's count everything together. Come on, count. 1, 2. You got to count here, not on the air.
The 54-year-old woman undergoes corneal biopsy for microcalcifications, revealing flat epithelial atypia. What's the most appropriate next step in management?
Surgical incision.
Hmm?
Surgical incision.
Count. Use the marker to count. 1,
Surgical excision. Okay.
2.
Number 2. Flat epithelial atypia is most frequently associated with which mammographic finding?
9,
Total microcalcification.
11, 12,
Hmm.
13, 14, 15. So 6 plus
Number 3.
is equal to
Which of the following features is characteristic of flat epithelial atypia on histology?
Specify columnar cell with mild ATPM and apical snots.
What is the
What did you
significance
count
of
now?
finding streaming cells in
Eh?
a duct with cribriform architecture on core biopsy?
Not be ADH, right?
Yes, multiple of ADH. Which molecular finding is commonly shared by FEA and other low-grade breast neoplasia?
Loss of heterozygosity.
Let's count 1, 2,
Heterozygosity assistant
7.
What flat epithelial atypia is considered which of the following?
Now let's count it together.
non-obligatorily precursor.
Which means it can progress or decide not to progress to ADH or low-grade carcinoma. Which of the following is incorrect about FEA?
3.
Into the following seems
Which of the following
always progress. Sorry, to carcinoma.
which histologic feature is typically absent in FEA?
Architectural complexity.
16. So 6 plus 10 is
Okay.
equal to right answer. 6 plus 10 is equal to what?
In FEA.
White pitch.
That means they don't have these things like cribriforming, Roman bridging, all this cribriforming, bridging is absent in FEA. Did you get that? Architectural complexity like bridging, cribriforming, they're usually absent in FEA. Okay. Question number 9.
Which number would that?
Question number that was 8. Question number 9. In the management of CCC without atypia, what is generally recommended?
Follow up with imaging.
Which of the following histology changes best support the diagnosis of ADH over FEA?
Keeping one spaces and bridges. They have complexity.
Yes. What is the primary reason surgical excision is recommended for FEA found on corneal biopsy?
Number one,
11.
to rule out higher grade lesion like ADH or DCIS.
What cytologic feature is not typical of FEA?
Demographic grade looking.
Homomorphic high-grade nuclei is not typical of FEA. Good. Usually low-grade polymorphism and low-grade nuclei. If it's high-grade, that will be clinging type DCIS. Which of the following statement is true regarding lumpectomy and radiation for FEA?
What is FE?
13.
It's true regarding lumpectomy and reduction of FEA. It is reserved for confirmed. It's true. Confirmed carcinoma, not FEA alone.
Regarding lumpectomy and radiation for FEA.
6 seconds.
It is reserved for confirmed carcinoma, not FEA alone. Okay.
Take away 1.
Good.
So why you wiping it?
So you can only do radiation if there's confirmed carcinoma. Which breast lesions are known to coexist with FEA?
ADH and what's the name? Lobular carcinoma in situ.
BCIS and LCIS
Only 1.
and tubular carcinoma.
Give me my marker.
What is the clinical implication of identifying cribriform species in columnar lesions?
It's no longer ADH. So this accelerated ATPA consistent with ADH.
When you start seeing complex architecture, no longer FEA, you are dealing with another entity. which is ADH. Read about 41. What's this?
Look like a nuclear
Globular
carcinoma.
LCI.
No, no notorious statement.
It's LCI, globular carcinoma in situ.
Okay, let's look at it. Let's look at it. This is normally multiple and bilateral here. Is depicted in a way as which is more
Take away from you. How many?
due to the girl. The placement of all the most
Six fingers.
I'll say C.
1, 2, 3, 4, 5, and 6. Take away one. How many is remaining?
I'll say C.
How many is remaining?
Okay, I agree with you.
All right, 5. And go and take your bath. Write 5 now. Let's go and take your bath. Write 5 here. Write 5. Write 5.
Let's see.
Time to take your bath. Continue later. Go. Okay. That's wrong. All these are a.
They are wrong.
The first part is correct.
Second part is wrong. These people, they know that everybody knows E-cardiac, but they know that we are not too familiar with this.
It's not generally possible I molecular model like this. It's a more common low molecular keratin.
After taking your bath,
Oh,
get it, okay? Time to take your bath.
I don't know much. I'm not very familiar with that. So 34 beta E12 is underneath for CK56. So 34 beta E12 is underneath for CK56.
yeah. High molecular keratin.
Yeah, CK56.
Taking your bath.
So it's actually negative for CK56. Wow. And only positive for low molecular weight keratin, CK818. What lesion did you see tonight that is positive for CK818? What lesion was that? FEA. FEA is positive for CK818.
Oh,
Yes.
Stand up and follow me.
So, and the positive for low molecular weight keratins like CK818, estrogen receptor, and GCDP15. So this histology image, we see small uniform discohesive cells. The cells are not touching each other, they're kind of discohesive, and they are distending the lobules. Yeah, but the global architecture, you can draw a line around it. You can see this fibrous tissue or collagen surrounding it. So it's, global architecture is well preserved but distended. They lack pleomorphism. We don't see necrosis. We don't see prominent nucleoli. We don't see all those things that we see with these cells. Classic features of LCI. So let's pick this. Oh, this is wrong. Can you imagine? That means we are correct. What did we choose actually?
which is C. C, D, Abi.
Now B. And we are correct. Can you
How do
imagine?
you know? What's their own answer?
The answer is the one we choose. ChatGPT was wrong.
It's not showing now.
After click now, you see that this is correct. This is the correct answer. I chose ChatGPT answer is wrong. Low carcinoma anxiety is associated with high grade of ductal hepatic carcinoma. The first statement is correct, but the second statement here is wrong. So are you with
It's
me?
not clear. The screen is not clear.
Let me share the screen again. Sorry. Lower carcinoma anxiety. This is it. Ooh. You quickly review it quickly. Do you know everything about LCIS?
I know the diagnosis. I know lots of it. I know it's mostly bilateral. The risk is bilateral.
Let me quickly review it. I'll try to be fast. And then we'll quickly.
Let's look at their own answer.
Well, look at the own answer already. I'll show you back. I'll show you now. So that I can understand the answer. I already understand what they're saying. This is the answer. This one.
I can't read it. It's not clear.
Let me share again. Are you using your laptop?
Yeah, I'm using laptop. Sometimes I will read it. Sometimes it will not be clear.
Is it clear now?
Waiting for it to show. Yes, it's clearer now.
Yeah, this is the answer.
Most of the background organs are emphasis ductal carcinoma, and the risk is slightly greater in the contralateral than the ipsilateral test. Usually with the high rate of ductal type carcinoma, it may occur bilateral, and risk is slightly greater in the bilateral than the contralateral.
Mm. Okay. So what do you understand?
Hmm?
Do you understand now?
Yeah, I understand the answer.
Good. So let me go review this quickly.
So what these ones are saying is that the cytokeratin is positive. Oh.
Listen.
I said the author of this book said of this material said the cytokeratin is positive. I even high molecular weight is positive.
The high molecular weight is positive, right? Yes,
Yeah.
that's why ChatGPT was wrong, right?
Hmm.
Yeah. Yes, it's wrong. Let's quickly review this quickly. If you look at this, in terms of classification, lobular carcinoma in situ is a misnomer. It's a clonal neoplastic proliferation of epithelial cells within lobules and ducts. You know, ductal carcinoma in situ, this size is within a duct. While lobular carcinoma in situ is within lobular units. Do you get the difference? So LCIS will appear within lobules. and its loss of k-cadherin. And lobular neoplasia is a spectrum. Are you aware?
Mm-hmm.
What is the spectrum of lobular neoplasia?
We have lobular hyperplasia,
What is the
lobular.
what's the lowest part of the spectrum?
Is it not lobular hyperplasia?
Atypical lobular hyperplasia, ALH, just like ADH,
Okay.
which will show partial acinar involvement. Number 2, classic LCIS. What about the classic LCIS? 50% of the acinar lobular units are filled and distended by neoplastic cells. Then we have pleomorphic LCIS. Pleomorphic LCIS means that you have LCIS where they have significant high-grade cytologic features. Then florid LCIS means the LCIS is distended with central necrosis and calcifications. Molecular alterations, there will be loss of E-cadherin due to genetic silencing of the CDH1 gene. CDH1 gene is what codes for E-cadherin. Beta-catenin defect can contribute to abnormal cytoskeletal connections and loss of cohesion. Remember that beta-catenin is also important for cell-cell adhesion. HER2 alterations can occur up to 40% in pleomorphic LCIs. Estrogen receptor is positive in LCIs, strong and diffuse, but less frequent in pleomorphic LCIs, which have apocrine features. Classic LCIs, the one that involves 50% of the lobules, is commoner in younger women and postmenopausal women. Younger postmenopausal women, 44 to 46. Pleomorphic or florid LCIs, approximately 60 years. And LCIs can be bilateral or multicentric in up to 80% of mastectomy specimens. LCIs cannot be detected by imaging. They can be discovered incidentally. I don't know what they mean by that. Maybe when you excise the breast for other lesions, you'll not find it. It doesn't always show calcifications. What kind of LCIs which can present with calcification? Sir? Hello, sir.
Hello.
What kinds of LCIs can present with calcifications? The pleomorphic and florid LCIs. They can be found in corneal biopsies and all that. One the classic LCIs, type A and type B. Are you there? Hello, sir. Hello? Hello? Hello, sir. Hello?
Hmm?
You're feeling sleepy.
Hello.
And it's a very important topic. Do you want to rest for a while?
If I rest, I'll be there for this morning. Now, did we answer question? Answer the question before, like round up this particular one.
Because we have not differentiated between classic LCIS, pleomorphic LCIS, florid LCIS.
Mm-hmm. Yeah, let's do it now.
Okay, this is classic LCIS.
Yeah.
What are the properties of classic LCIS?
Yes.
Yeah,
Yeah, this cohesive.
these cohesive cells that are monomorphic, it's abundant, it's monomorphic, and sometimes they have signal ring cells. We have type A or type B. Type A is small, round, uniform, like you see here. While type B is small cytoplasm and nucleoli. They occasionally have signal ring cells, pagetoid spread in ducts. So classic globular carcinoma in situ is characterized by neoplastic proliferation of small uniform discohesive cells that expand the acini of the TDLU. Signal ring cells are often present, like this one. This is a signet ring cell. Signet ring cell. See this ring. This is ring. Signet ring cell. This is loss of key cadherin in LCIS. That's the hallmark of LCIS. So what else can we use for this case?
What does that what?
What other stain can we use to look for to kind of
P120.
P120? So what we see in P120?
Cytoplasmic.
Yes. Why is it staining? Hey, you can see this is a terminal ductal lobular unit. If it's DCIS, you see, okay, sometimes it is almost want to resemble each other. But it's TDL, you can draw a line around it. It's involving the whole 100% of the TDLU, terminal ductal lobular unit. So is this classic LCIS, pleomorphic LCIS, or florid LCIS? Is florid because florid involves everything. The pleomorphic LCIS, classic involve like 50% of the lobular units. Pleomorphic LCIS and the florid LCIS. Sorry, classic LCIS cover 50% of terminal TDLU, whereas pleomorphic LCIS and wow, and florid LCIS are the ones that can fill up with TDLU. They can form confluence with little or no intervening stroma, central necrosis, and calcifications, and also present with detected mammography. Okay. This pleomorphic LCIS. Who is the ODA?
Almost a sheet.
Yeah.
Okay, there's still no visual, but
Cytoplasm can be seen here. Necrosis can sometimes be seen. And the pleomorphic LCIS is more likely to be ER negative and HER2 positive, just like luminal B something. Okay. Okay. DCIS usually displaces the luminal cells and fills the ducts. If it's DCIS, you distinct the luminal cells and fill the ducts. Okay. Purgatory spread of LCIS is cytokeratin. Budgetary growth is selected by IHC study showing luminal cells. So LCIS can be positive for CK56. Wow, look at it now. CK56 is positive for LCIS. The neoplastic globular cells are positive for CK18. So creatine will be positive for both LCIS,
Okay.
both high molecular weight keratin and low molecular weight keratin positive.
Okay, okay, okay. And the new platinum cells are possible for CK. I then still my epithelial cells there in lobular carcinoma in situ.
Yeah. What are these? Can you explain this concept here you are saying?
Signaling cells. Distinct mostly factor. Sorry.
Did you get this slide?
And yeah, those cells with eosinophilic secretions, which is a bit with signal ring appearance.
Very
You
good.
know, it's definitely
One
clear.
of the hallmark features of LCIS is signet ring appearance. So you see some of the cells will have these clear spaces. Okay, with mucin vacuole, call them mucin vacuoles. And then they'll push the nucleus to one side. So when you start seeing a lot of this, you can think of LCIS. This one has histiocytoid features. Histiocytoid features. Okay. Okay, this slide. Okay. Okay.
So the presence of specific malpresence.
The epithelial cells are present here. The epithelial cells are in the wrong places, away from the basement membrane where it's supposed to be. Like these are epithelial cells. My epithelial cells, they're away from the basement membrane where they're supposed to be. That's abnormally located my epithelial cells. It can occur in the case of LCIS because they become discohesive. Are you with me, sir?
I will too.
They become discohesive because of this, a lot of E-catecholamines. So the epithelial cells can become discohesive and then migrate into other cells. Like here, these dark browns are all my epithelial cells. They no longer be at the basement membrane. Okay. What is this? Okay, explain this P120 staining.
Yeah, cytoplasmic.
Yeah, this is the plasma staining. The nucleus is spared.
Mm.
Okay. Normally, it's a cytoplasmic staining, not cytoplasm. Sorry, cytoplasmic membrane staining. Understand? But when there is problem, it says cytoplasm. Here, cytoplasm stains with P120, and there's lots of icatherine.
Or normally it should be membrane staining.
That's
I
what.
say normally one P120 stain the
Yes,
membrane.
staining. Why now? Why is this called pleomorphic LCIS? I doubt this. It's difficult to differentiate this from DCIS actually in real life. So you do what's the way to differentiate these kids from DCIS? So why is this pleomorphic LCIS? Okay. Hello.
No,
Yes, it's a pleomorphic LCIS. Tell me about pleomorphic LCIS.
those ones have high grade nuclei, central necrosis, almost solid. It's a solid appearance. You know the doctors, the nuclear solid.
I think,
They have high grade nuclei, they have necrosis, they have calcification, and they appear solid. The architecture.
okay, so you got pleomorphism. The main thing is the necrosis. Can you see this necrosis? There's some calcification in the middle. There's necrosis here. Almost like common necrosis. The way to differentiate this is that this will be A category negative. Otherwise, it will almost look exactly like DCIs, common necrosis. So classic LCIs, 50% of acinar in lobular units are filled and distended by neoplastic cells. High-grade cytologic features. High-grade cytologic feature can be found in pleomorphic LCIs. And then florid LCI is the one with marked distension of central calcifications of focal necrosis. Pleomorphic LCIs with necrosis. This is ER. So if you see LCIS, that's ER negative. What kind of LCIS is that? Hmm?
Now, if I see
LCIS is usually ER positive. If you see LCIS that is ER negative, what kind of LCIS would that be?
pleomorphic,
Pleomorphic LCIs. Usually they have significant pleomorphism and they'll be ER negative. Of course, the way you differentiate LCIs from DCIs is by ecadherin and P120. They have what we call florid LCIs. Florid LCIs will have marked distension with central necrosis and calcification. Which of the LCIs will be ER negative, HER2 positive? Mhm. Sir, which of the LCIs? Okay, mention the four forms of lobular neoplasia, the four spectrums. Sir? Hello, sir.
Hello.
You want to go and rest? Let's finish up this one tomorrow.
Yeah, let's do that tomorrow. At
Eh?
least we'll be able to do something. Yes, yes. We'll finish it tomorrow.
Okay, no, because it's a very important topic, actually.
Yeah. Thank you.
Okay. Thank you, sir.
You're welcome.